In this high-yield psychiatry review, we will start with an approach to schizophrenia. There are 5 symptoms to look for: 1. Delusions, 2. Hallucinations, 3. Disorganized speech, 4. Disorganized behavior or catatonic behavior, and 5. Negative symptoms. If there are 2 or more present, one of which is symptom 1, 2, or 3, delusions, hallucinations, or disorganized speech, and these symptoms have been present for 6 months or longer, this is the diagnosis of schizophrenia. 2 or more symptoms for the duration of 1 to 6 months qualifies as a diagnosis of schizophreniform, and 1 day to 1 month is brief psychotic disorder. For completion, there are 2 cluster type A personality disorders, schizotypal and schizoid. Schizotypal, I want you to think magical thinking, odd behavior, paranoid, eccentric, while schizoid personality types prefer solitary lifestyles, lack enjoyment in social situations without symptoms of psychosis. Very high yield is the treatment for schizophrenia. Your first line antipsychotics are your typical antipsychotics. These include things like haloperidol, and they're all listed on the left side of the table. The overarching side effects from this first line agent list include extrapyramidal symptoms. You can also have anticholinergic symptoms as well, and specifically for chlorpromazine, you get the corneal deposition or the corneal deposits. Extrapyramidal symptoms are those dystonia, increased muscle tone, akathisia. They may present as pseudoparkinsonism, and tardive dyskinesia. Medications that are second generation are also known as our atypical, and those primarily block serotonin and act on the dopamine receptors. These medications exhibit less of the dramatic extrapyramidal symptoms but can cause metabolic syndrome. So think elevated lipid profile, elevated blood glucose, and weight gain. Out of this group, aripiprazole is the most weight neutral. Major depressive disorder is 5 or more of the SIGI-CAP symptoms plus number 1 or number 2 for the duration of at least 2 weeks' time. So you're going to have depressed mood or anhedonia plus 5 of those listed on the left-sided table there. So suicide ideation, lack thereof interest, guilt, decreased energy, decreased concentration, decreased or increased appetite, psychomotor symptoms, and sleep disturbance. There is changes throughout the sleep cycle in depression. Specifically, look for reduced stages 3 and 4 or the slow wave sleep. Major depressive disorder with atypical features includes hypersomnia, hyperphagia, reactive mood, hypersensitivity to interpersonal rejection. And then major depressive disorder with psychotic features, you want to think about treatment involving a SSRI and a second generation antipsychotic. Peripartum depression occurs 4 weeks after delivery. Electroconvulsive therapy is indicated in major depressive disorder pregnant patients who are unresponsive to pharmacological management. You also want to think about using electroconvulsive therapy in someone who refuses to eat or drink, exhibits catatonia, or is an immediate suicidal risk. Bereavement is the loss of a loved one, and that occurs for the duration of months. Seasonal affective disorder, think about someone having sugary cravings, hypersomnia, irritability, and you treat that with light therapy. SSRI discontinuation syndrome, most likely medication you're going to see this in is paroxetine, so you want to prevent this by having a slow taper. And then on your right side in this blue box, we're going to break down the difference between dysthymia and cyclothymic. Dysthymia is dys, Greek root for ill, bad, thymia for mood and emotion. So these patients have persistent depressed moods. You may see this written as persistent depressive disorder as well. And these patients will have at least 2 or more of the following symptoms from the left-sided table. Cyclothymic, on the other hand, is there's alternating periods of hypomania and mild to moderate depressive symptoms. The key here is that they are never symptom-free for greater than 2 months at a time. Now that we know the criteria for a major depressive disorder and a major depressive episode, we will compare and contrast the differences between bipolar I and bipolar II disorder. In bipolar I disorder, you qualify as having a manic episode and depression. So a manic episode includes 3 of the following symptoms in the pink box. for a duration of at least 1 week. So distractibility, insomnia, impulsiveness, thoughts of grandiose, flight of ideas, activity, agitation, pressured speech, and thoughtlessness. If you're unclear whether the patient is hypomanic or manic, and you cannot remember the mnemonic above, check if the question stem mentions the patient being hospitalized. Hospitalization for mania or hypomania, that automatically places the patient in the manic category and thus bipolar I. Bipolar II patients exhibit signs and symptoms of hypomania. They may have symptoms of insomnia, distractibility for 4 days, but they don't hit the manic or the mania criteria. To have bipolar II, you have to have at least one prior major depressive episode. Generalized anxiety disorder symptoms include a compilation of irritability, difficulty concentrating, unable to control worries, restlessness, feelings on edge, sleep impairment, which can also manifest as just muscle tension. The duration is 6 months of these symptoms, and the first line is cognitive behavioral therapy with an SSRI, such as sertraline, or an SNRI, such as venlafaxine. Panic attacks are described as the fear of the fear. Essentially, they have a patient will have palpitations, feelings of impending doom, and these symptoms occur for greater than 1 month in duration, and these patients will often worry about experiencing another panic attack. The most effective treatment is cognitive behavioral therapy, and you can also try propranolol as well. Agoraphobia includes the fear and avoidance of specific places and situations to avoid feelings of entrapment and embarrassment. These people may avoid the stimulus so much that they end up confined to their homes. The duration occurs for greater than 6 months' time, and the treatment is, you guessed it, cognitive behavioral therapy and an SSRI. Social anxiety disorder is typically, you may also see it as a social phobia. It's where people avoid eating in public, speaking in public, using public restrooms. The treatment is cognitive behavioral therapy. Specific phobias such as specific animals, critters, environments, blood, that's all treated the same. It's treated with cognitive behavioral therapy. Selective mutism is the failure to speak in specific situations, although the ability to comprehend is preserved. This occurs for greater than 1 month in duration, and it's treated with cognitive behavioral therapy. And then you can also undergo family therapy and trial of an SSRI as well. Separation anxiety is a patient will often complain of somatic symptoms to avoid school or work. If it occurs for greater than 4 weeks in kiddos or greater than 6 months in adults, then this warrants the diagnosis of separation anxiety. The first line treatment is cognitive behavioral therapy and family therapy, and then the second line therapy we usually reserve for the SSRI. Obsessive compulsive disorder is ruled by obsessions that cause anxiety with invasive thoughts. So the person then performs this compulsive behavior with relief. The treatment includes cognitive behavioral therapy, specifically exposure therapy. You want to also try an SSRI, and then a second line would be like an SNRI or a TCA such as clomipramine. Obsessive compulsive personality disorder is driven by perfectionism and detail, trying to organize and maintain control. These can interfere with completing tasks. Body dysmorphia, lots of them have this feeling to correct a perceived flaw, typically with makeup or dermatological procedures or plastic surgery. The treatment is SSRI and cognitive behavioral therapy. Hoarding is treated with cognitive behavioral therapy. Trichotillomania, or the compulsive pulling out of one's hair, that treatment is the SSRI, and you can also try second generation antipsychotics. The cognitive behavioral therapy you would specifically use is habit reversal training. Excoriations is skin picking. The treatment is cognitive behavioral therapy, habit reversal, and an SSRI. Adjustment disorder is emotional or behavioral symptoms within 3 months in response to an identifiable stressful life event. Acute stress, on the other hand, is often related to trauma occurring less than 1 month ago. The symptoms are occurring less than 1 month, and the treatment is an SSRI and cognitive behavioral therapy, exposure therapy. And then PTSD is the trauma occurred at any time, and the symptoms are a duration of greater than 1 month. The treatment is prazosin. There are 4 big takeaways for your high-yield geriatric portion of psychiatry shelf exam. This includes the Lewy body dementia. It's a cognitive decline and visual hallucinations, then presents with Parkinson-like symptoms. It occurs with rapid eye movement, sleep behavior disorder, pronounced antipsychotic sensitivity. You may see extrapyramidal symptoms, and the treatment is cholinesterase inhibitors for cognition and quetiapine or clozapine for psychotic symptoms. The second disorder I want you to know for the geriatric portion is the frontotemporal dementia. There are extreme changes in mood and personality, often inappropriate social behaviors, loss of empathy, and sensitivity to others' feelings. The treatment is supportive. You can try an SSRI like sertraline, but mostly it's supportive care at that point. Huntington's disease is that CAG repeat. It's on chromosome 4. It's an autosomal dominant disorder, and it's often seen with chorea. The treatment is tetrabenazine or an atypical antipsychotic. And then the fourth disease I'd like you to know for the geriatric portion is prion disease. This is a rapid cognitive decline with myoclonus and an increased startle period. This is like rapidly progressive. It's fatal. There's no cure, unfortunately, but you'll see that increased startle response. I want you to think of prion disease. Switching gears to the high-yield pediatric portion of the psychiatry shelf, there are a few different types of therapies or assessments that will show up on the shelf. Play therapy is very self-explanatory. There's also classroom observation. Formal neuropsychological testing includes things like IQ testing. And then the big 2 I want you to be able to discern is the Kaufman Assessment Battery for children, which helps understand the intelligence of children ages 2 through 12. And then the Wechsler Intelligence Scale for Children Revised assesses intelligence of children ages 6 to 16. There are specific learning disorders, and these would be reading problems, which would be dyslexia. You can also see it with writing and arithmetic, but the other big one is dyscalculia. Treatment for attention deficit hyperactive disorder, the first line you want to do a stimulant, methylphenidate, dextroamphetamine. The second line would be a norepinephrine reuptake inhibitor such as atoxamitine. And then alpha-2 agonists like guanfacine and clonidine are also other alternatives. Tics, those are multiple motor and at least one vocal tic for the duration of 1 year. There is a high comorbidity with OCD and ADHD. The treatment includes habit rehearsal. The first line therapies include alpha-2 agonists like clonidine, guanfacine. And then you can also use the partial D2 agonist aripiprazole. Oppositional defiant disorder. This is when the kids can get along with their peers, but then they're rude to the teachers, things like this. So you're going to have 2 episodes and it's going to last for 6 months, whereas conduct disorder involves physical aggression or violating rights, and these people will often be cruel to animals. Another high-yield pediatric psych concept is enuresis versus encopresis. Enuresis will often occur in children 5 years and older, and it's characterized by recurrent urination. There is a genetic predisposition, and the first line treatment is education, alarms, and if this therapy is ineffective, then you can start things like desmopressin or imipramine. And then encopresis can be seen around 4 years of age with recurrent defecation into inappropriate places. And then lastly, for the pediatric portion, disruptive mood dysregulation disorder, there are going to be 3 outbursts per week, inconsistent with developmental levels. The symptoms occur in 2 different settings, so think school and home. With a recurrent verbal or physical outbursts, these outbursts go with no more than 3 months of symptoms-free behavior and start before the age of 10. The first line treatment is cognitive behavioral therapy, and this will often occur in kiddos in a particular question stem. Depersonalization and derealization. This is when the patient will detach from oneself and its surroundings, often described as an out-of-body experience. This is the depersonalization component, and it's often in like a daydream world around them. That's the derealization state. These patients, the reality testing remains intact. Dissociate identity disorder will present with someone having multiple distinct personalities. And then dissociative amnesia, I typically remember this one by thinking about a wandering fugitive or like a fugitive in like a fugue state. These folks will often forget who they are, their name, things like this. All right, guys, a few more slides. You're hanging in there, doing great. So, somatic symptom disorder patients, they're going to present for the duration of 6 months with a bodily complaint like pain, for example. The treatment is frequent visits. Functional neurological symptom disorder or functional neurologic disorder is also known as conversion disorder. It's when a patient often characterized with someone who complains of neurological changes, think vision changes, numbness, tingling, but these patients are without neurological pathology. The treatment is therapy. Then the last one is illness anxiety. This is often like the hypochondriac symptoms. They're going to wax and wane, and the patient is preoccupied with acquiring a specific illness for the duration of over 6 months. The treatment includes cognitive behavioral therapy, frequent visits, and an SSRI. Factitious disorder is when someone deceives others by appearing sick, falsely ill presenting. When the factitious disorder is imposed on someone else, as in the case of a mother presenting a child as being sick or ill or injured, this is often coined Munchausen by proxy. And then malingering includes intentional reporting of symptoms for external gain. You will get a question, at least one, on eating disorders. Binge eating disorder is characterized by frequent large amounts of feeding, often occurring within a 2-hour period of time, at least one time per week with a duration of 3 months. These folks often have normal BMIs, and the first line treatment is an SSRI. Anorexia, on the other hand, is when there is a BMI of less than 18. They're going to present with either in the question stem, they'll have like mitral valve prolapse, hyponatremia, hypocalcemia, hypokalemia, alkalosis, some sort of heart arrhythmia. They will have an elevated growth hormone and cortisol with decreased gonadotropin releasing hormone. You want to watch out for refeeding syndrome in these patients. They may have fluid retention, decreased phos, mag, calcium. You want to slowly replace these electrolytes because these patients can go into respiratory failure, delirium. They can even have severe seizures. So the treatment for these patients is cognitive behavioral therapy, SSRI, and you want nutrition on board for nutritional counseling. And then lastly, those that have anorexia are at a very high risk of suicide. Bulimia is when you see this in a normal weight and there's some sort of compensation or compensatory pattern, such as extreme workouts or binging one time a week for a duration of 3 months. Laboratory abnormalities include metabolic acidosis secondary to laxative use. You may see an elevated amylase, and the treatment is SSRI, such as fluoxetine, for example. Sleep disorders is all encompassing for this table here. Just see the disorder and then the treatment, and that should be high yield for you enough. So sleep terrors, that's often in children. They're going to have profound response while sleeping. They will not remember it, however, and the treatment is just reassurance. Nightmare disorder, on the other hand, the treatment is desensitization, imagery, and rehearsal therapy. REM sleep behavior disorder, that's where these patients think violent. They have violent REM. And so the treatment for them is clonazepam. Narcolepsy, the treatment is these people are going to have like sudden and frequent episodes of someone just like falling asleep. So they have it's related to hypocretin, and it's with decreased REM sleep latency. So these guys, you want to treat them with modafinil. And then catatonic cataplexy, you treat with benzos. And then the first line treatment for insomnia is cognitive behavioral therapy. And then if it's refractory, then you can do like a zolpidem, for example. All right, guys, thanks for hanging in there. One more minute of your time. This is just a rapid fire here. Charles Bonnet syndrome is well-formed visual hallucinations in patients who become blind secondary to macular degeneration. NMS is treated with dantrolene, bromocriptine, and amantadine. Dystonia, or the sudden sustained contractions of the neck, eyes, tongue, mouth, all of those from antipsychotic use, the treatment is Benadryl. Same thing with akathisia, that's that restlessness. They're unable to sit still. Secondary to antipsychotic use, the treatment is beta blocker. You also see Parkinsonian. This is when they have the gradual onset tremor, rigidity, bradykinesia. The treatment is benztropine. And then tardive dyskinesia, that prolonged dyskinesia of mouth, face, extremities, that's all for greater than 6 months duration. You want to treat them with valbenazine or clozapine. Kleptomania, these folks have urges to steal, so the first line treatment is cognitive behavioral therapy, and you can try desensitization therapies in addition to SSRI, and there is even some literature supporting naltrexone. Benzos that are not metabolized in the liver are lorazepam, oxazepam, and temazepam. The treatment of seasonal affective disorder is light therapy. Lamotrigine, which is great for bipolar depression, you want to watch out for something called Stevens-Johnson syndrome. Lithium is metabolized in the kidney. The lithium troughs for therapeutic target ranges are from 0.6 to 1.2. And if it's greater than 2.5, you may need the patient may need dialysis. Valproic acid is metabolized in the liver. And then lastly, guys, when transitioning to an SSRI to an MAO, you want to wait a few weeks to let the SSRI wash out. So if it's like fluoxetine, for example, because it's a longer acting SSRI, you're going to wait 5 to 6 weeks to prevent serotonin syndrome. And then the patient will present, if they have serotonin syndrome, they'll present with hyperreflexia, rigidity, and altered mental status. This can be life-threatening, so you want to treat promptly with cyproheptadine. And that's it for the high-yield psychiatry shelf review. Comment below, message me if you have any questions, and I hope this was helpful, guys. Thank you so much for your time and support.